India. With that, I will hand it over to you, Dr. Arjun, to take us through another important element of gastrointestinal symptoms, which is constipation and bowel obstruction. Thank you.
Good evening, all. Thank you, ma'am. Ma'am, I'll just start sharing the slide actually. Am I audible actually?
Yes, you're audible. Please go ahead.
Are the slides visible?
No, sir.
No. The share screen itself didn't come up, Dr. Arjun.
Second session of GI symptoms actually. So today we'll be dealing with two major symptoms. One is constipation and other is bowel obstruction. So I'll start out with constipation, following which we'll have the next session of bowel obstruction. Next slide, please. So the major aim of today's session is to have an understanding of what is constipation, why is it important, what are the multiple causes of constipation, and how do we assess it. Hello, is the audio clear now?
That's right. I was also about to say, what is that? It was okay. Do they want you to raise the volume or something? Let us ask. Just a minute, Arjun. Audio not clear is what they. Can you just hear Dr. Madhu? Can you hear or can you specify what is that? I could hear him.
A little bit of echo.
Volume. That's what. Little bit of volume. That's what I felt. Okay. Just maybe come closer to the mic or something, Arjun. That should be okay.
Okay. Am I audible now?
Yes, maybe as pre-process, little bit of background noise is there. You start off, Arjun. We'll see. As last time, if there's any difference, I will prompt you.
Okay. So the first thing which you're going to ask is what is constipation actually? So constipation per se is the passage of small volume of feces infrequently and with difficulty. So the persistent, difficult, infrequent, or seemingly incomplete defecation is called as constipation. So there's a common perception among us that whenever someone says they're having constipation, or whenever the patient or person doesn't pass feces, then only we can consider as constipation. So that's a wrong concept. That's a misconception actually. So any time when there is any inadequate or incomplete defecation, or there is persistent difficulty or infrequent defecation, all these constitute defecation. It's not just the absence of bowel movement per se, but also the incomplete act of defecation itself. Next slide. So constipation is one of the most mismanaged symptoms in our practice actually, not only in palliative care practice, but also in common surgical or medical practice as such. The reason being is that this is one symptom which the patient most of the time they don't come to us with. Like it is one thing which we have to ask them to assess. Most of the time the patients who present to us will be complaining of severe pain, shortness of breath, nausea, vomiting, or maybe delirium also. And once we start taking a detailed history, when we reach the point of constipation, like when we ask them whether when was the last bowel movement or something, they say that no, the bowel hasn't been moved for the past 3 days, 4 days, or 1 or 2 weeks actually. And this is thing which they normally ignore. Not only the patient, also the caregivers, and most of the physicians also ignore it. We as palliative care physicians should not ignore this one symptom actually. So why is constipation one of the most mismanaged symptom? There are multiple reasons for it. One is the most common misconception, that like diet. So generally the people who we see, they will have decreased oral intake of food, or sometimes they might be just taking very liquid diet actually, like juices or semi-solid foods as such. So they feel like since they're not taking anything solid as such, so the bowel movement should not happen. So whenever they're taking liquids or any semi-solid diet, urine can will be passed and there won't be bowel movement actually. This is one misconception which both the patient as well as the caregivers will be having. So that is one thing which we need to address. So whenever Or sometimes they won't be taking anything orally also. That is also one thing which we commonly encounter in our practice. Like when you ask them when was the last bowel one, they will be asking us like he has not been eating, he or she hasn't been eating anything for the past 4 to 5 days. So there hasn't been, so it's normal not to have bowel movement. So always tell them that even if they're taking anything oral or not taking anything, there should be a normal bowel movement in every 2 to 3 days actually. That is a normal standard which we have to keep in our mind. So every 2 to 3 days there should be a bowel movement actually. So the next reason for which this is one of the most mismanaged symptom is that is there is ignorance of psychological factors actually. So I believe all of us will agree that whenever we are using the washroom or toilet for bowel movement, that is one of the most private or personal time which we use. And most of the time, what happens is that whenever a patient or anyone is admitted in hospital, also they lose their privacy actually. They might be bed bound, or they might be able to use the washroom, or the washroom facilities won't be that much hygienic actually. All this will cause them not to use the washroom actually. And sometimes there's also loss of control. Like they might have a normal routine of bowel movement, like going every day in the morning or in the evening actually. But once they are admitted somewhere, once they have any health ailment, that daily routine is affected actually, due to which they won't be able to go to the washroom or pass their bowels. Following this, they might develop constipation. Other is the overlooking of side effects actually. So most of our patients will be on multiple medications actually, not only opioids actually, other anticholinergics, SSRIs, all this chemo medications, antibiotics. So once they're using multiple medication, they all this medication itself can cause constipation actually, and this is one thing which we most commonly overlook. Next is the suboptimal use of laxatives actually. So sometimes we might prescribe laxatives to the patient and they might not be using it. The reason being, they might say this is a medicine which is used for bowel movement actually, and if they use it, the frequency of bowel movement might be very high, or the patient might be dependent on the usage of laxative for bowel movement. So this is one thing which they don't want, or even the patient doesn't want, and they won't be using the laxatives properly. Like they might be using it once every 2 days, like every alternate days, or the dose might be reduced by themselves. So this in itself can cause constipation. And sometimes there are certain atypical presentations of constipation, like the patient might come with dyspeptic symptoms, urinary tract infections, delirium, and sometimes diarrhea, like overflow diarrhea, spurious diarrhea actually. So overflow diarrhea is one thing which we encounter very frequently actually, and both the patient and the caregivers feel like the patient is having loose stools, so that they stop taking the laxatives. And what in turn happens is that the constipation, which is already there, it just builds up much more further. Sometimes when with this loose stool, they might go to a nearby health center or something, and they might be prescribed any anti-motility agents actually, which will further aggravate the constipation. The reason why behind spurious diarrhea is that sometimes due to
Just a
chronic
minute, Arjun. There was a message that it's still not clear, but I feel it's okay. Just let us ask the rest. Is it better now or not?
I believe the flow is continuous, like volume was also good. Just a bit of like some device noise coming in at times. Otherwise, it was fine from our end. Yeah, the background noise, a little bit of background noise was.
is the background noise still there, or has it come down now?
Actually, it is not continuous, Dr. Arjun. Like maybe when you are saying say 4 to 5 sentences, one time that comes. So it's not continuous, but maybe we can continue with the session.
Like if the voice disturbance to just put it in the chat box. We'll see what we can do to address it.
Sure, we will keep you posted.
So, like I was saying, the reason behind spurious diarrhea is that sometimes during chronic constipation, the entire bowel might be loaded with fecal content actually. So, and any new fecal content that is being produced will come through the sides like in liquid form actually, and it might present as diarrhea or loose stools. And it is very essential from our part to differentiate between spurious diarrhea as well as chronic constipation and normal diarrhea. Next slide, please. So there's a criteria actually for definition of constipation. There's based on the Rome criteria. So we can consider constipation when there's at least two or more of the following symptoms. These are straining during at least 25% of the defecation, a sensation of anorectal obstruction during at least 25% of the defecation, lumpy or hard stools at least 25% of the time, and fewer than 3 bowel movements per week. To go through criteria also, it also doesn't mention absence of bowel movement. The last criteria is fewer than 3 bowel movements actually. And whenever there's straining during 25, at least 25% defecation or sensation of incomplete defecation, at least 25%, we can consider that to be constipation actually. And not really, no, it's so constipation, not just the absence of bowel movement, but also whenever there's an incomplete defecation or sense of straining or of bowel movement or bowel movement actually. Next slide, please. So now we know what is constipation actually. Now next thing is, why is constipation such a worry for us actually? So what usually happens is that in advanced disorders, constipation itself can cause colic abdominal pain, anorexia, nausea, vomiting, urinary retention, anxiety, confusion, and delirium in elderly. So constipation itself, we won't feel like it is a thing we have to manage, like it won't be causing that much harm. But whenever in advance there's constipation, it can mimic as the patient can present to us with severe pain actually. And if we don't, whenever patient presents to us severe abdominal pain or nausea or vomiting to say, you have to always ask them when was the last bowel movement actually. So what generally happens is that a patient might come to us with severe abdominal pain or colicky type of abdominal pain, and we might just increase the analgesic dose, be it morphine or any other analgesic, and we will send the patient home back home. What happens is that since the constipation is not relieved, suppose for example we hike the dose of morphine actually. There's already constipation for this patient, and by just by hiking the dose of morphine, the pain is not going to subside, and the constipation is going to build up further. This then might cause the patient to present back to us in severe delirium or with severe nausea and vomiting. So whenever we suspect constipation in a patient, we must actively manage or aggressively manage this infection, because each one of the other complications which can arise from constipation is very much difficult for us to manage. So it's better to manage constipation itself initially rather than waiting it to progress too much further. Next slide, please. So we'll talk about the causes of constipation. So there are multiple causes. One is pharmacological, then there's metabolic cause, neurological, structural, and functional. Pharmacological cause. So these are certain agents which can cause constipation. These are antacids, anti-epileptics, antiemetics, anticholinergics, opioids, antidepressants, antipsychotics, and so on. If we just go through these medications, in our setting, we use multiple agents, like we use opioids, we use anticholinergics, we use anti-epileptics and antacids. So all these medications can cause constipation. Most of the time, we just relate constipation to opioids actually, but that's a wrong thought. Opioids can cause constipation, I agree with that, but other agents like anticholinergics, anti-epileptics, antacids, all these can also cause constipation. We must keep this in our mind because most of the time there will be a combination of all these 3 or 4 medications actually. So if each one of them can cause constipation, combining all of them together will anyway for sure cause constipation actually. Next cause is metabolic. So severe dehydration, hypercalcemia, hypokalemia, uremia, all this can also cause constipation. And neurological, so whenever we're suspecting malaligned spinal cord compression, we usually also assess for the bowel and bladder habits actually. It gives us a clue actually what level of spinal cord is involved and how quickly should we aggressively manage the spinal cord compression. And sometimes due to sacral nerve infiltration also there's constipation actually. Next is the structural causes. So whenever there's a tumor in the pelvic region or there is post-RT, like radiation therapy, radiotherapy induced fibrosis, or any painful anorectal condition or interluminal obstruction, it can also manifest as constipation. In case of painful anorectal condition, patients who are having like anal rectal malignancies actually, there's a mass there. Sometimes they present to us sometimes severe pain whenever they defecate actually. So what they usually do is that sometimes they, instead of taking the pain medication, they feel like with the passage of bowel movement, the pain is aggravating. So they might just take anti-motility agents from the nearby pharmacy, and they may just start using it. So addressing this is also very important for us. Next is functional action. So depression or a bed bout patient, all these patients, their normal bowel pattern is altered action. It can also cause constipation. Next slide, please. Now you can continue with this. Previous slide, previous. Other is diet action. So like I said in the earlier slide, one of the misconception is that the patient isn't taking anything orally or is just on a liquid diet. So there is constipation. So diet itself can contribute to constipation actually, but it is not just the entire cause. So whenever there is a low fiber intake or low fluid intake, there are chances of constipation. Other comorbidities like diabetes, hypothyroidism also can cause constipation. Now, this diabetes is of paramount importance for us because majority of the patients with diabetes is in our country. And the patients who we see will, most of them will be having diabetes or hypothyroidism. So we have to also look into it. Other causes are immobility, inactivity, advanced stage, and inability to obey the call. So whenever we are seeing patients who are bedbound or who had a CVA actually, or due to that hemiparesis, these patients are usually bedridden most of the time. So since there isn't any mobility actually, the normal bowel functions won't have, and that can also cause constipation. Other is advanced stage. Advanced stage is one thing which is most common in our geriatric patients actually. They might be having normal bowel habits, like they might be moving daily or once or twice a day in their age, but as the age progresses, they might be having difficulty actually. Oth- Other is the inability to obey call. That means suppose they might need to go past fecal matter sometime, and they might due to the setting where they are, due to that constraint, they won't be able to go to the washroom. That might itself can cause constipation. Because in my practice, I've seen all these causes for constipation actually, like patient being immobile, not having the adequate or the washroom facility, like the toilet which they were used to was Indian, but which they were admitted was Western. The toilet facility wasn't good. Medications, all these are causes which we more commonly encounter in our practice actually. And patient will come to us with constipation, and when we ask them why they aren't taking any laxatives or why they're not willing for anymore, they might say that the washroom available facility available isn't good, it isn't hygiene, so we don't want to use the laxative. Sometimes we also see patients who are bedridden or in the home having constipation because of the resource limitation. Like bedbound patients, they might be using diapers or underpads actually for bowel movement, and these things has a certain financial implication for the caregivers. So if they are unable to afford these things, they might not be giving laxatives to the patients regularly, and this itself can cause constipation. So just assuming that they're not taking laxative, or why they are not taking laxative is also an important thing which you need to assess. Because if a patient is not able to afford a diaper or something and just hiking a laxative is pointless because they won't be given this laxative. Here the issue is the resource limitation. Next slide, please. So, please. So we discussed about the multiple causes of constipation. So these are the most common causes of constipation in a palliative care patient. So one is obvious opioids. So this is one thing which opioids, which all of you will be aware of by now. I know opioids will no will cause constipation, and it is not a dose limiting thing, and there won't be any tolerance to constipation. That means that whenever the patient is on opioid, he or she will always develop constipation as a side effect. And this is one thing which usually other departments also associate us with. That sometimes cause hesitancy from their side also. Like whenever we start opioids as morphine in any patient, then another concern which come to us is that this it will cause constipation to the patient. Why are you constipating the patient? Next is dehydration. Then there's reduced mobility. Hypercalcemia. Hypercalcemia is commonly encountered in malignant patients. Actually, malignancy is one thing where more common who need palliative care. For them, we have to also rule hypercalcemia, neurological deficits, and other agents like antacids, ondansetron, anticholinergics. All of these are also causes constipation. Next slide. So, like I said, morphine causes constipation. Actually. So, how does morphine cause constipation? So there are one mechanism actually. The major mechanism is that it decreases the propulsive intestinal activity actually. As there isn't any propulsive activity in the intestine, the usual peristalsis or usual movement of fecal matter doesn't happen. This in turn can cause constipation. Next is by increasing the non-propulsive activity. And there's also, since there isn't any propulsive intestinal activity, what happens is that the fecal content which is present in our bowel is also condensed water actually. So there isn't a normal propulsive activity. Like the transit time is prolonged actually. Due to this, what happens is that there's increased time available for water reabsorption. Since water is reabsorbed more, the fecal content becomes much more harder actually. If the fecal content becomes much more harder, it causes much more severe strain for the patient to defecate. Not only the patient, even for us, if the transit time is prolonged, the fecal content becomes much more harder actually. And this impairs the ability for us to strain, like it causes more straining. And if you're able to recall the definition of constipation, if there's at least straining for more than 25% of fecal bowel movement, it is called as constipation. Another thing is that most of our patients, they are frail actually, so they won't be able to strain by themselves. Other is sometimes they might have shortness of breath. So the act of passing bowel itself can aggravate exertional dyspnea. In this in turn, they won't be that much willing to pass the bowel movement. Other is it inhibits the secretory motor neurons, which in which sense it again decreases the fluid which enters the gut. Again, this is the decreasing the water content in the fecal content. And next, it reduces the sensation of rectal distension. Like fecal impaction also happens. The next slide. So how do we go about this actually? So if you see in our practice actually, so there are certain questions which we ask routinely, be it an inpatient or outpatient or home care services. We usually ask us how the patient symptoms, how they're doing all this thing. And all the time, whenever we see the patient, we ask them how their last bowel movement was. We daily ask this question. If it's a, and ask us how it's going. So one thing we need to note here is that patient's normal last bowel movement, whenever you ask me that, we must also keep in mind how their routine bowel movements are actually. So all the people who visit their bowel movements won't be the same actually. Some of us might be using or going through the washroom for bowel movements, might be having bowel movements 2 or 3 times a day. Some might be just having it once a day actually. And sometimes it may be, for some people, it may be once in 2 days actually. So whenever we are asking the patient's bowel movement, it's mandatory to ask them how their routine bowel movement was. So once we establish when the last bowel movement was, we have to also ask them about the consistency, size, and volume. So, and the next is whether there was any bleeding or mucus in the stool. Then we also ask them the ease of passage actually. That means whether they had to strain or not. And most of the time when they say the bowels are being moved regularly, when we ask them about the consistency, actually they say that it was hard consistency or the amount of fecal content was very less actually. Next about the ease of passage, they might say that they had to strain a lot for the bowel movement. Next is the sense of incomplete empty. So this is one thing which we get in different way actually. Sometimes we all these questions we won't be asking daily. That's one thing which I've seen in our practice. We might ask when the last bowel movement, how it was actually. Sometimes what we hear is that the patient will come to us that I want to go, I'm feeling discomfort when I'm passing my bowels or I'm feeling unhappy with my bowel movement actually. And at the same time, the caregiver will be saying that he's going to the washroom daily once or twice a day. He's always in the washroom. I don't know why he's saying he's having incomplete bowel movement. So you have to always ask them whether they have feeling of incomplete emptying actually. Like they might say they might have used the washroom and the bowel movement might have happened actually, but sometimes they might feel like there's still some content left in the abdomen. Next is fecal incontinence. Also ask them whether there's any incontinence in fecal matter. Excellent. And overflow. So this is the Bristol stool chart actually. So this is the one standardized tool which we have to used to assess the bowel movement. Actually, it tells us of the consistency, size, and difficulty as such. And it is we don't use it in our OP setting as well as home care setting actually, but it is better to use this stool chart in our inpatient facility actually. And ideally, we have to show the patient the stool chart and ask them how their bowel movement was. Of this number, type 3 and type 4 are normal actually, with type 1 and 2 indicating constipation, while type 6 and 7 are more indicating of diarrhea. So always during your daily rounds, morning, You have to ask them how their bowel movements was using the Bristol stool chart. If the doctors are not able to do, at least the nursing care should be doing this daily and regular. Next slide, please. Now, when should we be suspicious of constipation actually? Suppose most of the time they may say the oral intake has decreased actually. So in our oral examination, we have to look for dehydration, whether there is a depression. The next is a physical examination of abdomen. Always, whenever you're suspecting constipation, actually look for the oral cavity as well as the abdomen. Abdomen, we palpate the abdomen to examine for whether any fecal content, like fecal, if any mass is there in abdomen. Also, we examine for bowel sounds, whether the bowel sounds are present with hypoactive or hyperactive action. And it is also always mentioned that in whenever we are suspecting constipation, a rectal examination must be done to assess what is this like whether the rectum is balloony or loaded with fecal content or not. And almost we must take care whenever doing the rectal examination to avoid any rectal bleeding actually. And after this also, if it isn't that much clear, following our clinical examination, we can also order an abdominal X-ray. Next slide. So like I said, rectal examination is always important. Most of the time what we do is that we don't do a rectal examination. Patient will say he or she is having constipation and we just note it down. Always do a rectal examination to assess what is the rectal feeling, whether it's loaded with rectal content, whether it's balloony or whether it's narrow. Next slide. So in rectal examination, these are the things which we can find out. One is the rectum is empty and collapsed. So this indicates a functioning bowel. So there won't be any constipation. Suppose when we do the rectal examination, rectum is empty, but it is dilated. It indicates that there is a fecal content in the rectum and it might be high up in the bowel. Suppose the rectum, when we feel a balloon, like it's highly dilated, it means that there has been gross constipation actually. And if there is fecal content in the rectum, we have to determine the consistency and manage accordingly. The reason why we have to determine the consistency because if it's hard stools, giving normal laxatives or putting suppository or enema won't work as such. We might have to do a manual evacuation action. And suppose sometimes we might also get a tumor mass, like patients who are having anorectal carcinomas might have a mass in the rectal region actually. And based on the mass size, we can also understand whether should we give enema or not? Because sometimes if there's a mass which is completely obstructing the anal canal or pathway, giving an enema is pointless in such case because the fecal content might impact the mass and it might cause lead to bleeding or severe pain actually. In such situation, having an opinion from the surgical side regarding what further management can be done would be a better form. Next slide. So like I mentioned earlier, rather than trying to treat constipation, preventing constipation is much more important. And we can recall, like ma'am said during the session of nausea and vomiting, the hand that charts smoking should always write a laxative with this. Your prescription of opioid is considered incomplete if you don't write a laxative. Laxative, most of the time we refer for a stimulant laxative. Next one. So regarding management. So like any symptom, we have got non-pharmacological management as well as pharmacological measures. Non-pharmacological measures, like I said earlier, there should be daily assessment, how the fecal bowel movement was of the patient. Then we have to always promote mobility actually. Whenever a patient is bedbound, the chance of them having a normal bowel movement is much more low. Other is to assess their toilet facility, access to toilet facility, whether they are able to access it easily, whether it's if a patient is wheelchair bound, whether the toilet facility has wheelchair friendly actually, whether wheelchair is wheelchair accessible, which type of washroom they are more commonly using. All this is of importance actually. Prompt response to patient's call, privacy. So if patient is in the ward, we can how the common sense which we say is that suppose we are passing our bowel movements, how would you expect someone barging in between to see you actually? The same thing with the patient. We have to consider suppose a patient is bedbound and if he's passing fecal actually bowel movements, we must give that privacy to the patient actually. Others reassessing their dietary and food intake and also giving attention to other things. Next one. No, the pharmacological management is by giving prescribing laxatives actually. So laxatives as such are classified into based on the mechanism of action. One are bulk forming agents, next is fecal softness, then there are osmotic laxatives, And there is stimulant laxatives and other agents actually. Other agents are the ones which are not primarily a laxative agent, but due to its additional action, it helps us in managing constipation. Now, the examples of bulk forming agents are isaphibula and methyl cellulose. Example of fecal softeners are liquid paraffin, docusate sodium. Osmotic laxatives are macrogol, lactulose, magnesium salt, magnesium hydroxide suspension. The stimulant laxatives based on the area where they work. Sometimes certain stimulant laxatives works on the small bone. These are disaccordal, gantron, whilst other laxatives works on the larger bone, like sen and sodium picosanthate. Like other agents are the prokinetic agents, metoclopramide and erythromycin. Of this, the most commonly used agents in my setting is bisacodyl as well as liquid paraffin. Actually, we also use lactulose. Next slide, please. So I have briefly mentioned about each category of drugs and how they work actually. So the way bulk forming agents works is that it increases the fecal mass actually. So as the fecal mass gets increased, it stimulates peristalsis and there's bulkier and softer streams. However, one thing which you have to keep in mind is that bulk forming agents are usually unsuitable for elderly or debilitated patients as they extra fluid to create this bulk action. Next, and so it is not normally used in paratic acidity. The other laxative which is used osmotic osmotic laxatives. These are lactose, which are non-absorbable sugars which exert an osmotic influence which causes water retention in the lumen. If you're able to recall the cause, the major cause of constipation is that the water which is present in the fecal content is getting reabsorbed in our bowel actually. So most of lactose, this is due to the prolonged transit time. So what's the laxative? What is it? It increases the bulk formation, causes water retention actually, and this in turn facilitates bowel movement. Lactose is also used in management of hepatic encephalopathy actually because it causes scavenges the urea nitrogenous waste products in hepatic encephalopathy. Other thing we should have to take in care caution is that it can cause dehydration and can also cause cramping and nausea. This is one thing which we commonly encounter in our practice. Patients might not prefer lactose due to its nausea sensation and they might say that they don't want it. Next slide, please. Next is fecal softener, liquid paraffin. So liquid paraffin is one of the most commonly popularly used stool softener and laxatives. The trade name being cremafin actually. So it is usually not used alone as a laxative and it's usually combined with a stimulant laxative like bisacodyl. Next slide. Stimulant laxative. So bisacodyl is the stimulant laxative which I have most commonly seen being used actually. So it has got a direct action on the nitric plexus and the submucosal plexus and has got both motor and secretory action. Motor instant, it acts on the small bowel and it stimulates the bowel movement action. And one thing we should note is that it should be avoided in cases of complete obstruction. I'll be talking about complete obstruction in some time in this session itself. Next slide, please. So how do we go with the prescription of laxative? So the way we go is that whenever we are starting morphine or any opioids per se, or like we are managing constantly, we start with the stimulant laxative. The tab bisacodyl 10 mg HS. So that formulation, I believe the strength is 5 mg actually. So we write 5 mg 2 HS actually. We can, if we want, we can add a softener, or we need not add a softener actually. It is based on the patient choice. Like sometimes they might say that they're having heart stress. So in such cases, we add a softener. Most commonly, softener which we use is liquid paraffin, like cremafin. After that, even if constipation is persisting, we hike the dose of the stimulant laxative. We make it 5, 5, 10 action. And we are going to continue with the softener. And even after that, the constipation is persisting, we go with 10 mg TID actually with the softener. Suppose even with 10 mg TID, and also one thing you have to keep in mind is that the softener laxative dose can also be hiked equally. Like it's not that we have to first hike the stimulant laxative, then wait. So this takes only 1 to 3 days. If you're able to recall, like I mentioned earlier in the beginning of the session, there should be a normal bowel movement every 2 to 3 days actually, and we have to aggressively manage. So what we do is we start a tab bisacodyl 10 mg HS with suppose cremafin 50 ml. Then the next day, if constipation is still persistent, we can go to 10 mg BD with cremafin also 15 ml BD actually. And then we can make it TID along with cremafin. And even if that there's constipation, we go with rectal measures. Rectal measures, ideally we start with suppository, Dalclac suppository, 2 tablets at a time. Follow if even after that there's constipation, we go with enema. Prochylasis enema is a more commonly used enema. We can also go with soap and water enema based on the setting where you are and the resources which you have in hand. Even after giving low enema or a high enema, constipation is still persisting, we go with manual evacuation. Next slide. So before going to so there should be, with our aggressive management of laxative, there should be a bowel movement every 2 to 3 days actually. More than 3 days, there should not be a constipation. So that is the one thing we should keep in mind. So once we hike the laxative and the patient is comfortable with that, we have to continue those same rules. Next is regarding spurious diarrhea. So spurious diarrhea is a sudden onset of diarrhea after a period of constipation. So the patient will be saying that, like when we take the history, actually, that in those tools, we always take the history, like whether there was any precipitating factor, any infection, any fever, food intake from outside, associated nausea, vomiting. So in spurious diarrhea, the classic history which they say is that there was a history of constipation for a long time, 1 week or 2 weeks, fecal matter wasn't going on. Then he developed sudden loose stools. So this suggests of chronic constipation and fecal infection actually. And most of the time what happens is that they might stop their laxative and they might start taking anti-motility agents for spurious diarrhea, which in turn will aggravate the constipation. So the way we have to manage this is that we have to do a rectal examination, digital evacuation if there is constipation, followed by regularization of laxative. The most common challenge we face in spurious diarrhea is convincing the patient and caregiver that it is not diarrhea but constipation actually, because most of the time when they come to us, they say the patient is having loose stools, and when we say that it's not loose stools, it's constipation, they feel like we, like how can we say it's constipation, because the way they say is that the patient passed loose stools like for the past 2 to 3 days and it can't be constipation. So ideally, generally what we say, we explain to them what is the reason behind it, and if it's feasible, drawing a diagram, doing a diagrammatic representation of what is happening inside will help them realize what is the real issue, and that will help us in managing much further. Next slide. So to conclude our session of constipation, constipation is a symptom and not a disease, and it's one of the most mismanaged symptom in our setting actually. And most of the time we feel like we have written a laxative, we should be able to manage the constipation actually. One thing we have to keep in mind is that no laxative works if we do not give the enough dosage or if we do not give effort. And we have to also be aware of the adverse effect of these laxatives and whether it's palatable for the patient. And we usually combine a stool softener with a stimulant. Next slide, please. Next is bowel obstruction actually. Is there any doubt about constipation? If there is any doubt, you can put it in the chat box. I'm audible, right?
Yes, sir.
Yes, Arjun, you are audible. There's nothing on the chat, so just go ahead, and then after that, maybe we can get them to ask questions or unmute and speak.
So the next topic is of bowel obstruction. Next slide, please. So bowel obstruction is one of the most challenging symptoms which we face in our practice actually. So the way we diagnose is it, the signs and symptoms of and with a of obstruction along with the radiological evidence actually. And most of the time, bowel obstruction is due to cancer or any malignancy related treatment actually. Next slide, please. So bowel obstruction is actually a bit difficult area to manage. The reason being there is huge variation in how the patient presents to it. The signs and symptoms varies actually, and the management plan also changes because bowel obstruction is one of the symptoms in which there should be a multidisciplinary team involved. Multidisciplinary team involvement in the sense not only the palliative care team, it must also involve the radiation oncology team, the medical oncology team, as well as the surgical oncology. All the teams should be involved in management of all obstruction. And since multiple teams are involved, the management plan changes considerably because sometimes the approach with surgical team might go will be entirely different to how the palliative care team might be seeing the patient. Similarly, the medical oncology team might be also seeing an entirely different point. So it is one of the most toughest symptoms which we have to manage due to the multiple factors involved. And generally, even though there are multiple guidelines, what we say is that What we say is that the management protocol should be based from case to case. So what is the magnitude of bowel obstruction? So bowel obstruction most commonly occurs in advanced stage, and once there is bowel obstruction, the expected median survival is from 1 to 3 months. So bowel obstruction itself is an indicator of poor prognosis, and we have to initiate a conversation at that time itself regarding the patient's poor prognosis. And the bowel obstruction occur anywhere from the esophagus to the rectum actually. However, the most common site of bowel obstruction is small bowel obstruction and is more commonly seen in colonic cancers. Like the percentage is from 4 to 24%, while in gynecological malignancy it comes from 5 to 42%. Other malignancies like breast cancer, gastric carcinoma, lung carcinoma, pancreatic cancer can also manifest bowel obstruction if there is any peritoneal deposits or no. Next slide. So, what are the different types of obstruction? So, obstruction can be classified into mechanical or functional, partial obstruction or complete obstruction, single obstruction or multiple site obstruction. So, like based on the causative itself, the management plan changes. And if generally what we say is that if there's partial obstruction, it can be managed medically actually, instead of going for a surgical intervention. The reason being is that any intra-abdominal surgery, if you are able to recall, will cause adhesions actually, which in turn will cause chances of another repeat of another episode of recurrence of another obstruction actually. And if there is a single site obstruction, actually, usually single site complete obstruction, what we prefer is surgical intervention. While for multiple site obstruction, we don't go for a surgical intervention. And in malignant causes, it can be intraluminal or intramural, like infiltration of intestinal muscle, or extrinsic, like obstruction from outside, like a mass present adjoining to the bowel area can cause obstruction to it. Or if the mass is inside the bowel itself, it can also cause obstruction. Sometimes there might be also obstruction by involvement of the neurological component. The involvement of the plexus itself can cause bowel obstruction. Next slide. So functional obstruction is usually due to treatment, and this treatment can be adhesions from the surgery, desmoplastic reactions to chemotherapy, torsions of mass, internal hemorrhage. All this adhesions of surgery is more commonly encountered actually, because most of the time patients who are having any GI or gynecological malignancy, they might undergo any cytoreduction surgeries or tumor reduction surgeries actually, following which they might develop multiple adhesions actually, and they may present to us with coming to severe abdominal. So this is one thing which you have to keep in our mind actually. And sometimes chemotherapy also, the reaction due to chemotherapy can also cause obstruction. Next slide, please. Now, rarely, like I mentioned earlier, rarely there's intestinal pseudo obstruction due to destruction of the enteric neurons, and sometimes drugs also, like certain, like I mentioned, morphine sometimes can cause a wrong cancer time. It can also cause severe ileus, paralytic ileus, and there is diabetic neuropathy also. Next slide. So, what is the pathophysiology behind bowel obstruction? So, whenever there is an obstruction, the content which is present in a bowel stimulates the gastric content, as well as there's increased gastric, biliary, and pancreatic secretions. As the secretion increases, the bowel again gets distended and the cycle continues actually. So whenever the secretion increases, there's decrease in the intraluminal sodium and water reabsorption and increased mucosal sodium and water secretion, which in turn causes further distension. And as the bowel gets further distended, it causes in bloating, pain, nausea, and vomiting. Next slide. So this is the pathophysiology behind obstruction. So what all can happen with you? Most of the time in our practice, or like multiple studies also state the same way. Patients who are having bowel obstruction, their general condition deteriorates not due to the obstruction per se. It is due to the metabolic and septic rearrangements which happens due to the obstruction. And these two are also one of the causes for the causes of death in these patients actually. So what happens is that there is hypovolemia actually. This in turn can cause renal failure leading to oliguria, acidemia, and hemoconcentration actually. Due to the electrolyte imbalance, there will be metabolic alkalosis, hypochloremia, hypokalemia. This is more commonly seen in high level obstruction. Sometimes acidosis can also happen due to ischemia and sepsis actually. So as the bowel is getting distended, there will cause it will elevate the diaphragm actually, causing decrease in pulmonary ventilation actually, and this can cause shortness of breath for the patient. Sometimes there's passage of toxins on intestinal contents to the systemic and lymphatic circulation action. This will manifest as sepsis at a later stage. Next slide. So general rule of thumb is that whenever the site of obstruction is higher, the symptoms will be more, there will be less signs to elicit action. However, if the obstruction is present in the lower side, there will be less symptoms, while more signs can be elicited. Next. I'll be talking about it in the coming slides for this. The next slide, please. So, what are the signs and symptoms we can expect in patients with bowel obstruction? Like I mentioned earlier, always the signs and symptoms of obstruction is based on the site of obstruction. Like for example, if there's a gastric outlet obstruction, the patient will present to us with complaints of early and severe nausea and vomiting instead of pain. However, in small bowel obstruction, there will be more of a pain component associated with nausea and vomiting actually. So we have to always differentiate based on the symptom. Like the way we go about with assessing the site of obstruction is based on the clinical presentation and the radiological or imaging findings section. Next slide, please. And like I mentioned earlier, like the lower the obstruction, the symptoms will come much less, and there will be signs. So in large bowel obstruction, symptoms will appear much later, and there is considerable distension in the abdomen, and there can also be diarrhea actually with the bacterial overgrowth. Next slide. So one thing which commonly present is pain actually. So the pain in which patient present in bowel obstruction will be of two types: a continuous type of pain or a cramping type of pain. So this cramping type of pain is usually presented after the meal actually. So what the classic history which they say is that he or she was very much comfortable actually. However, after taking something orally, some food, some substance, they develop severe cramping type of pain. This in turn causes severe aversion of the patient to taking further meals and will further aggravate the anorexia or cachexia which the patient is having, which will further and will affect the general condition of the patient, causes severe fatigue. This in turn will affect the caregivers also, because in our setting, giving food is a way in which our relatives will love to show affection actually. So once the patient's oral intake comes down due to severe pain, they will also much more concerned. Next slide. Next is nausea and vomiting. If you're able to recall in my session of nausea and vomiting, one thing which we assessed in history was the content of vomitus section. What was the content of vomitus? So in bowel obstruction, based on the content of vomiting, we are able to assess which side the obstruction is. In large bowel obstruction, the content of vomiting will be fecal. Fecal content will be coming in vomiting actually. While in small bowel obstruction, as well as gastric outlet obstruction, the content will be biliary. Biliary in the sense there will be a greenish yellowish color of the vomitus section. Next slide. And constipation. Constipation will also be there due to bowel obstruction actually. And sometimes the way we differentiate between complete and partial obstruction is with the presence of flatus action. If flatus is being passed, it may indicate an incomplete obstruction or partial obstruction. If flatus is also absent, it means it's a complete obstruction. Based on this question of flatus itself, our entire management plan changes. Because the way we manage partial obstruction is entirely different to the way we manage complete obstruction. Next is by auscultating the abdomen to assess for the bowel sounds. There will be an altered bowel sounds whenever a suspended bowel obstruction. It can be absent, hypoactive, the distal segments, or it can be hyperactive in the proximal segments as the bowel will be trying to push through the obstruction. Next slide, please. So these are the signs and symptoms actually. So in proximal obstruction, like I said, pain can be continuous in nature, colicky in type of pain. So in proximal obstruction, pain is one of the earlier symptoms, and it will be most commonly periumbilical in region, followed like short, intermittent cramping type of pain. However, in distal obstruction, pain is a late symptom actually. It is usually localized to the site of pain, like which site of the colon the obstruction is, it will be localized to that area, and it will be more like a deep visceral type of pain, and there will be long intervals between the cramps action. And next is semblance of vomiting action. So in proximal obstruction, there will be large amount of vomiting. It will water bilious in nature. There will be no fallout or little fallout action. However, in distal obstruction, the vomiting content will be small, but it will be particulate in nature, and it will be followed. So most of the time, distal obstruction, like large bowel obstruction, will come with fecal vomiting actually, which will cause severe distress. And next is regarding abdominal distension. Actually, in proximal obstruction, the abdominal distension is usually absent, while in distal obstruction is usually present. And constipation will be present in both proximal as well as distal obstruction. Next slide. So, how do we evaluate the patient? So, bowel obstruction as such is not a paralytic emergency. Actually, paralytic emergencies are usually bleeding, spinal cord compression, or bowel obstruction. Whenever we have a patient with bowel obstruction, in the way we go with a workup is by evaluating the patient's overall status and their disease trajectory, like what stage of the disease trajectory the patient is, based on and their goals of care, like what is the patient want and what is the patient's caregivers want actually. Based on this only, we make a care plan for the patient. So it is not like any patient with bowel obstruction, be it partial or complete obstruction, should have the same care plan. Always we have to look at the overall performance status for the patient. How is the PPS? What is the ECOG? Like is it ECOG 1, 2, 3, or 4? Or what is PPS 30, 40, 50, or 60? Based on that, our care plan changes entirely. And also the stage of disease. Suppose if it's in the initial stage of malignancy with a good performance status, we always go for an aggressive management of bowel obstruction, which may even include a surgical intervention actually. However, the disease is in a stage 4 disease, like it is a metastatic disease with a poor performance status. Going for an aggressive management is not justified actually. And our goals of care again change. If it's an earlier stage of the disease, we will go for it much for a curative intent of purpose. However, in a late stage disease, our goal of care will be comfort care or symptom management. Irrespective of a goal of care, we must always address the pain, nausea, vomiting, and the fluid status of the patient. They usually also do a blood investigation to assess the hydration status as well as the electrolyte status of the patient. Hydration status in the sense, if you are able to recall, due to the decreased blood volume, there is oliguria which might affect the renal parameters. So the patient can also go into AKI, acute kidney injury, which is pre-renal cause, which can be corrected by giving aggressive hydration. Next slide, please. So this is a typical X-ray. Am I audible actually? Uh, am I audible?
There was disturbance in between the
Okay. So there's a construction happening in the hospital nearby. So that's the issue actually. The previous slide, please.
And also along with your mic, also there is something, as someone has mentioned, no, along with your mic, we can hear something rubbing your mic or something like that. I don't know why. Just on and off, Arjun.
So this is a slide. This is an X-ray of a patient who has abdominal obstruction, actually bowel obstruction. So you can see there is a multiple air fluid levels actually, and you can also see the bowel channels. Next slide, please. So plain X-ray. So in bowel obstruction, we usually ask for an X-ray erect abdomen actually, and proximal obstruction, like I mentioned earlier, there is usually normally no definitive value. However, in distal obstruction, we can see multiple air fluid levels and dilated bowel lobes actually. And it also helps us in ruling out constipation, which can manifest as pseudo obstruction. The sensitivity of a plain X-ray abdomen is less than 50%. So usually we do it as a screening test actually. If the manifestation for a CT scan, we ask for an X-ray abdomen erect first, following which we'll decide whether should we go for a CT abdomen. Next slide. These are, you can be able to see the bowel shadows actually in supine position as well as the F. Next slide. So CT is considered as one of the gold standards for diagnosing bowel obstruction, and it has got nearly 100%. It has got 100% sensitivity and 96% specificity. And while doing a CT scan, we are able to locate the obstruction, the extent of obstruction, and differentiate between whether it's a benign cause, malignant cause, and whether it's a true obstruction or pseudo obstruction. It also helps us in making decision regarding whether we have to do a surgical intervention, or even in surgical intervention, whether we have to go with endoscopic intervention or palliation action. And it also defines the area around the obstruction, whether it's lymphadenopathy, omental mass, and adhesions. There's also one more guideline which says that we should not do a CT abdomen in bowel obstruction if the performance status of the patient is poor. Like if the PPS is 30%, 40%, or if the patient has got an ECOG 3 or 4, at advanced stage malignancy, there's no point doing a CT scan actually. We can just do an X-ray abdomen and decide what should be the next step of intervention. This is from the Oxford Express of palliative medicine actually. The reason they suggest is that there's a waste of resource doing CT scan if we are not going for a surgical intervention. A patient with a poor performance status and advanced malignancy won't be fit for a surgical intervention most of the time. So doing a CT scan just for the sake of it isn't justified in such cases. Generally, we say go for an extra abdomen, then we go for CT scan, but also keep in mind before going for the CT scan whether any surgical intervention is possible in this patient. Next slide. So management. Next slide. So general management is, like I said, each management of bowel obstruction is always based on from patient to patient actually. So generally, however, these are certain general guidelines which we keep in mind. One is frequent mouth care. Since the most of the time in bowel obstruction, the patient will be nil per orally, like NPO. Though they won't be taking anything orally, as they're not taking anything orally, their mouth might be dry and there will be poor oral hygiene. So we have to give frequent mouth care followed by offering them ice cubes to suck actually. So small amount of, and we can also feed them small amounts of food and fluid. And if patient is dehydrated and not dying, we can also consider for IV hydration. Sub-Q fluid can also be considered, but the reason with sub-Q fluid is that the amount of fluid which we can give is very less and it takes much more time consuming. And regarding offering ice to suck and small amounts of food and foods to eat, most of the time patient will be NPO and they will the complaint which they raise is that I feel dryness of mouth or I'm feeling hunger or I want to eat something like I need to know the taste of such. In such cases, we can advise them to have some amount of fluid so that the mouth dryness of mouth is addressed actually. And regarding the taste issue, what we say is that ask them to chew the food and spit it out actually. Rather than swallowing it, we can also ask them chew the food and spit it out so that they have that perception of the taste actually. These are certain things which we consider in end of life solutions actually. Next slide. So the pain is there in bowel obstruction. How do we reduce the pain actually? One agent which we prefer is steroids, and the next is antispasmodics. The next agent is opioids actually. Opioids from a mainstay of management on bowel obstruction from our side actually, but like I mentioned earlier, since it's a multidisciplinary involvement, this is one of the controversial points actually. Most of the time when we start opioids for the pain management in patients with bowel obstruction, the surgical side or the medical oncologist side won't agree with our mind, saying that the patient is already having bowel obstruction and constipation, you are going to aggravate the same problem. But opioids is one of the NCG guideline actually, National Cancer Grid guideline for management bowel obstruction also suggests opioids, especially morphine for the management of pain in bowel obstruction. So we can give morphine and opioids in management of bowel obstruction. And the route always, since the patient won't be able to take orally, we usually prefer a sub-Q route actually more than an IV route. Next slide, please. So the role of steroid is that it decreases the bowel wall edema if anything is there, or if there's a malignancy, any malignant edema due to that will also be reduced. And the dose with which we go for dexamethasone is a slightly higher dose. We go for nearly 60 milligrams sub-Q thrice for 3 days actually, and we assess whether there's any response or not. And one thing which you have to keep in our mind is that whenever we're giving dexamethasone or any steroids actually, we usually prefer to give the steroids in the morning and afternoon dose itself. Like there are certain institutes where we don't give steroids at night. The reason being it will make the patient hyperexcited, there might be delirium. So whenever we're prescribing steroids actually, try to give it between the morning and afternoon dose itself, or a single dose in the morning itself. Next slide. And like 16 mg is the dose which we have prescribed. We can also go up to 32 or 24 milligram of steroids actually to assess the response. And to stimulate gut motility, we also give metoclopramide, 30 to 120 milligrams sub-Q. We start with 10 milligram TDS tablet if the patient is able to tolerate orally. And one thing we have to keep in mind is that if there is complete obstruction or any gut column. So what we generally say do is that if we're suspecting complete obstruction, we give a short dose of metoclopramide and we reassess whether the patient is having severe pain. If the patient develops severe pain, that means it's a complete obstruction and we have to stop metoclopramide. The reason being metoclopramide is a prokinetic agent and it will stimulate peristalsis. And the partial obstruction helps us in relieving the obstruction. However, in complete obstruction, since the entire bowel wall is obliterated, giving a prokinetic agent like metoclopramide will aggravate the pain. Next slide, please. Like for complete obstruction not dealing with upper measures, we have to focus on treating symptoms rather than underlying cause. Like in such situation, instead of going for a curative intent, we go for a symptom management or symptom management. Like what is the major symptom affecting the patient? Based on that, our care plan will change entirely. Next. To reduce secretions, we also go with hyosin butyl bromide. The dose is 40 to 250 milligram per day subcutaneous. You can also go for ranitidine infusion, 200 milligram per day. And somatostatin analog, like octreotide, decreases the acid secretion, increases intestinal motility, the bile flow and spinal circulation actually. And this usually when reserved for high volume vomiters, and dosage is 100 to 600 microgram per day of continuous subcutaneous infusion. Before starting octreotide, we usually go give a fair trial of steroids, hyoscine, and ranitidine actually. Even after that, if it's still persisting, we go for a trial of octreotide actually. The reason being, octreotide is slightly more expensive. Next slide. And there will be nausea and vomiting due to obstruction. So the drugs which we use, since metoclopramide is contraindicated in complete obstruction, we go with haloperidol or promethazine, and dose being 2.5 to 5 milligram per day sub-Q. And for promethazine, it is 25 milligram PA. Next slide. And since in bowel obstruction there will also be constipation actually, so if the rectal area is loaded, we can do general rectal measures like giving a or small dose of softness can also be used. Sometimes we also go with enema actually, we give enema continuously so that the obstruction can be, like if it's fecal impaction causing pseudo obstruction, we have to manage it aggressively by giving high up enema repeatedly, like once or twice a day, it's for 1 or 2 days. Next slide. Now, this what I mentioned till now were the surgical options available. Were the sorry, the medical options available? What are the surgical options available? Surgical options available are complete resection actually. Next is the lysis of adhesion, creating a stoma, debulking surgeries following by chemotherapy. So these are certain options which are like resecting the bowel area which has got obstruction, and we also sometimes they also consider anastomosis. If the proximal segment and the distal segment is still functioning, they might just resect the obstructed site and add anastomose between these two sites. The primary intention of a palliative care surgery is to improve the quality of life and symptom. This is not a curative option as such, because a patient who had developed obstruction might again further develop obstruction down the line actually, and a surgical intervention itself can cause further adhesions, which will further cause obstructions. The next slide. Next is the interventional management. So most of the time in bowel obstruction, we insert a nasogastric tube actually, or RT aspiration actually. This is useful in proximal bowel obstruction. So this is just a temporary measure actually. What it does is that the gastric secretion, like I said, due to the obstruction, there is a fecal the content is there in the bowel, which will stimulate the bowel, increase the gastric secretion, which again further distend the bowel actually. So the way we go with NG tube is that the secretions which are present in the bowel is vented out through the nasogastric tube. As there is decreased secretion, there is decreased distance. The distension also decreases, which in turn will decrease the vomiting, and this will also decrease the discomfort which the patient has. However, one of the most common issues which we see with Ryle's tube aspiration or NG tube aspiration is that the presence of NG tube itself causes certain discomfort to the patient. And there can be pain due to the insertion, the way we insert the NG tube. This is a procedural pain, sinusitis, pharyngitis, aspiration, or inversion of the nasal cartilage or esophagus. And sometimes social isolation also. Because once we insert an NG tube, we connect it to a bag actually, and the gastric content will be drawing out through the NG tube. So it will be slightly greenish yellowish. Due to this, the patient himself or herself might not be able to attend the usual social commitments, and sometimes there is also stigma associated. They might feel the patient to be unclean or unkept, and they might avoid the patient, which will cause further psychological issues to the patient. Excellent. Next treatment which is possible is venting gastrostomy. So this is considered in patients who are unresponsive to medical management with multiple levels of obstruction, poor performance skill, and who are not candidate for surgery with life expectancy of less than 1 month. There's a huge relief for symptoms. Nearly 90% of cases, there's huge relief for symptoms. And however, it is contraindicated in patients with tumor encasing the stomach, diffuse carcinomatosis, massive ascites, previous abdominal surgery. So again, here the intent is purely palliative actually, because you're not giving multiple medical medications. If the symptoms are not being persisting, it's causing huge burden to the patient. We can consider venting gastrostomy. Next slide, please. Sometimes we can also consider stenting, like gastric outflow stenting or proximal small bowel stent, colonic stenting. Laxation treatment can also be considered as restriction, and failure rates are high. Palliative RT is considered if it's just a single site of obstruction, and this in turn also helps in decreasing the edema and relieving the obstruction. So one thing which you commonly encounter is TPN actually. So this is more commonly seen from the surgical side. So whenever the usual management which I have seen in my practice from surgical oncology is that they usually keep the patient NPO and they insert a Ralston aspiration and go with an antispasmodic agent and steroid action. And based on that, they go with this is the conservative management which they go with. And if surgical intervention positive, they go with the surgical intervention. So sometimes they also write for a TPN actually. So TPN isn't usually justified in a palliative care patient until and unless there's a minimal tumor burden and the patient is a candidate for definitive surgery. There's got a good performance skill. That means that suppose if the patient, like I mentioned earlier, the general condition of the patient is poor or the performance status of the patient is poor, going for TPN causes unnecessary burden to the patient actually. However, if we feel like he has got a good performance status and a definitive surgery can be considered, then we can consider TPN as due to the obstruction, the patient general condition will start deteriorating and it may make him unfit for the surgery. Next. So, like I mentioned, it's using Gula. So, like the summary of bowel obstruction is that patients with bowel obstruction require evaluation for their disease trajectory and goals of care in deciding how aggressive to address the symptom. Pain, nausea, vomiting are the commonly addressed symptoms, and the medications can be given parenterally, sublingually, transdermally. Transdermally, like for pain, we can also consider fentanyl patch, patches actually. And patient and family members need to be comfortable to the use of medication. There should be good psychosocial support. And ideally, whenever we see a patient with bowel obstruction, like I mentioned initially itself, it's not like one size fits all rule. Each patient we have to consider what is their general condition, what are their expectancies, what is their goal of care actually. And based on that, we have to make a care plan tailored to each patient rather than go for general approach. Like I mentioned, it's a multidisciplinary involvement. Like we have to involve the patient's wishes and caregivers' wishes actually. What is the input from the medical oncology team? What's the input from radiation oncology team? What's the input from the surgical oncology team? And based on that, we have to only do interventions which we feel will be beneficial for the patient. This doesn't mean that every patient with bowel obstruction can be done surgically managed, or every patient with bowel obstruction should be put on RT and NPO. Because, like I mentioned earlier, suppose the patient is having a stage 4 disease with multiple site obstruction, and the prognosis comes down to about 1 to 3 months actually, the survival period. In such a situation, keeping a patient early isn't justified because the reason we keep the patient NPO there is that to help the survival of the patient. But if we are aware that the patient general condition is going to deteriorate, most of the time which I've encountered in my practice is that they are most of the time their wishes is that they have want to take something orally. Even with severe pain or something, they will say that I want to take something oral, I'm not eating anything oral, I need that taste action. In such situation, we ask them to take some amount of food orally, and if there are certain food substances which they want to taste, we ask them to chew it and spit it out so that the taste, that sensation is there with the dish. Next images. These are the references which I have used actually. Like the presentation is over actually. So I think I have overshot my time actually. So if there is any doubt, you can just put it in the chat box. I'll try to address it very quickly.
Thank you, Dr. Arjun. Like as you mentioned, no, this has to be dealt on an individual patient basis. And so you have given an overview on everything that they need to be aware and then take it from there according to each patient's, like patient status, condition of the disease, goals of care, and then very important, what is that the patient wants. So all these to be kept in mind and then dealt with accordingly. And as you mentioned, they can either, at present, there are no queries or anything in the chat box. Maybe we can go ahead with the case presentation and then come back for the discussion for both. Will that be okay, Sripriya? Can you go ahead to do the case presentation?
Yes, ma'am, as per your wish. We are sharing the screen.
Am I audible? Good evening, everyone.
Yes,
Yes,
Dr.
please go
Ashwini.
ahead, Ashwati, Dr. Ashwati.
Myself, Dr. Ashwati. I'm working in General Surgery Department, Dr. Mupin's Medical College, Wayanad. So here, please the next first slide, please. Here we have a 70-year-old lady with intestinal obstruction secondary to descending colon adenocarcinoma. Next slide. So her presenting complaints were abdominal pain for 1 week duration, which was progressively increasing, associated with constipation, progressive abdominal distension, and she also complained of nausea with poor appetite. Next slide, please. Yeah. So the history of illness was she was a 70-year-old lady accompanied by her son and daughter-in-law, presented with complaints of into our emergency department with complaints of progressive abdominal pain followed associated with the constipation and nausea and loss of appetite. The abdominal distension was also gradually progressing. Patient was very anxious as were the bystanders. Apart from her systemic hypertension, there was no significant any past history or treatment history available. Next slide. On examination, the patient was conscious, well-oriented, febrile, pulse was 100 beats per minute, other than vitals were stable. On per abdomen examination, it was soft, moderately distended. Tenderness was present over the left lumbar region. Bowel sounds were present, and per rectum, it was empty and collapsed. So, next slide. The relevant investigations, her hemoglobin was on the lower side. Apart from that, electrolytes were normal. Even blood urea creatinine was okay. So we proceeded with a CCT abdomen and pelvis since we are suspecting a malignant etiology in her, considering her age. So CCT abdomen and pelvis was done, which showed circumferential enhancing wall thickening, which was causing a significant luminal obstruction in the mid-descending colon on the left side, mid-descending colon. And associated with that, there was a significantly dilated proximal large bowel, and even the small bowel loops are prominent. And there were significant ileocolic and left colic lymph nodes, and was opined to be of a neoplastic etiology. So after resuscitation in ICU, we took her up for surgery. Anterior section with transverse colostomy was done. And the histopathological report came as adenocarcinoma of colon with lymph node. So whatever lymph nodes we dissected came out to be positive for metastasis. And it was not shown in the CT. However, the omentum looked little suspicious. So an omental biopsy was also taken, which also showed omental metastasis. So stage was T3N1, M1. So the patient was referred to medical oncology post-surgery, and she has received chemotherapy also. On follow-up after subsequent surgery, subsequently, she also developed vague lumpish feel in the abdomen. Mostly it was supposed to be omental caking. We did an ultrasound. I didn't add the report here. Omental caking, and is mostly due to METs. And she was having on and off episodes of subacute bowel obstruction, which didn't require any hospital admission or so. She settled on itself on bowel rest at home only. Next slide. So the psychosocial aspects here are, first thing, most important, she was not in a position to accept the nature of the illness, and her family did not disclose her the same in full gravity. She knows that it is cancer, but she doesn't know that it has got omental meds, everything, and the bystanders themselves took time to adjust the same. So the patient was in a depressed mood and has completely cut down her social life because of the colostomy. That was her main concern. She says she feels disgusted about it, to meet anyone, to go to temple. She's a very religious person. To go to temple, she wants to undergo the stoma closure surgery, which is not clinically advised for her. The patient's son and daughter-in-law takes care of the mother well, but also finds it very difficult to manage the patient as she is adamant about undergoing the surgery and get rid of the colostomy. Family members, they don't want the mother to undergo any further major surgeries or investigations per se, or in their own words, to suffer in hospital ICU. Next slide. The medication that she received through the course, chemotherapeutic drugs, as per, since it is omental meds and all, the medical oncology advised to give only oral capecitabine. Multivitamins were given, and on and off for the abdominal pain, NSAIDs was given, and she was, the pain was settling. We had given laparotomy wound care and the stoma site care. Next slide, please. Okay, the main concern in this case is colostomy care, because the patient was very reluctant to even try learning the stoma care as a long-term thing. She was adamant about getting rid of the stoma and doing a stoma closure surgery. It needs training for the patient and also the caregivers. She has developed even skin excoriation around the stoma. There was intermittent episodes of abdominal pain and subacute intestinal obstruction. Patient was not fully aware of her illness, even though she knows it is malignancy. The oral food intake, which is actually she's able to take because of the stoma was functioning, but she was not, because she was in a depressed mood. Plus, whatever she takes, she thinks is coming out of this. So to reduce the stoma output, she did all those. And the patient was reluctant for social interaction because of the stoma in situ, not cooperating with the caregivers, and the bystanders worried about the patient's behavior towards them. At the same time, they don't want their mother to know that she has a terminal illness. Where the financial requirements were well met because they have a good health insurance coverage. Next slide, please. So we have a 70-year-old lady with adenocarcinoma descending colon with lymph node and omental mets post anterior resection with transverse colostomy post chemotherapy. She has stoma set skin excoriations, intermittent abdominal pain and blotting sensation, possibility of subacute intestinal obstruction due to omental deposits, and a recurrence of malignancy needs to be considered. Next slide, please. So the discussion points are, we should consider, is it ethical not to completely disclose the nature of the illness to the patient who is conscious and with good comprehension? And is the patient and the family in question, are they actually having a quality of life even after we are providing her a colostomy? She's able to take orally. Still, I don't think they are having a good quality life. Are they both, even the patient and the family, receptive for palliative care? If so, how to provide them one? How to uplift this patient mentally, and how to train the caregivers, not only in the physical care, but also the mental care for the patient as well as themselves. Thank you.
Thank you, Dr. Ashwati, first to bringing up this case and see appropriate one. Like this is many patients, as you said, no, like awareness is something to be taught to them about colostomy. What is that? See, at that point of time, I know patient might have not been very well or something, but explaining everything to her, was she aware that she will have a colostomy before surgery?
Yes, yes. That consent was taken. Actually, even I was not in the actual surgical team. It's happened in my own hospital. So I have followed up. The consent, everything was taken to her. I have even met the patient once in OPD.
No. The thing is that, no, as Dr. Raghavan was mentioning to us, she would have been told colostomy. Was she aware what colostomy is something she will have?
Actually, madam, what is that? She thought the colostomy was temporary. That was the issue. Because initially in the CT report, she was a well-doing patient. As you can see, her vitals, her status, good, everything was good. She was well in all other matters. And even the CT was showing no evidence of any peritoneal deposits, nothing. So that time, even the doctors were saying it may be temporary, but she was very positive that, and she thought it was a temporary thing. That's why she knows that it can be closed. So that was the issue there. She knew everything about colostomy. She thought it was for a limited period of time. Yeah, because she has never been to hospital, so she cannot accept. That's what the bystanders or the relatives.
Denial, no? So normally we say, so that's it's there when each one of us gets to that stage, no? That is where the issue will come. Her accepting what it is, then understanding, then going through it. That's the important thing. So those are things, no, that's why communication again and again we'll be coming back to that. We say, and then how much they understand, how much they've digested, how much they've taken in. Everything is important because they are the ones who have to face it on a day-to-day basis. Okay, we may say colostomy. She needs to know what it is, and then how is that managed on a daily basis. Everything she needs to be aware of. So those are things which we have to stress and explain a bit more. And then like to see, I'm just going through your, like see, we can have a discussion on all of this. Like see, is it ethical not to completely, see, all of you have had a session on ethics. in ethics itself, you can have collusion. Okay, is this ethical? Is that telling it to her or not telling it to her? Both you can argue for and against. Okay, from patient point of view, from the family point of view, and from our point of view, what is that? Is that our duty to convey? Okay, so I would say like we can go with these one by one, and so that is the first bit, and then is the patient and family in question having a quality of both? Are they both receptive for palliative care? If so, how to provide them? Exactly. So what is the facility available you have there? How much they are aware, and how much is possible for them to take it? And then, like, see, you may need inpatient, or like whether she can come for outpatient visits, or is there a home care team? And then how to uplift this patient mentally, and then how to train the caregivers, not only in physical. That's all. Their multimodal management will come. Just let me have a look at the chat box, and then Arjun, you can also I will pass it on to you. I'll just read the question which is in the chat box. Was the nature of colostomy temporary or sort of permanent? It a discussion point during consent. So that's what I have asked. So yeah. So you're
So at the time of
go ahead.
surgery, we tell them that it could be permanent because we don't know what is inside. Even if the CT says something, always we have surprises inside. So we always tell them that it could be temporary, it could be permanent, depending upon what is the condition and depending upon the histopathological report. So if her report was there was no mental meds or something, she
Correct,
could have gone for a closure later.
Closure.
Yeah, that was only because of some clinical suspicion we took the mental biopsy, which turned out, but later on it clinically also proven right that she developed mental thinking, everything. So mostly she will be having peritoneal deposits, serosal deposits, everything. So it is always mentioned in the consent, but as madam said, how much she perceived needs to be questioned.
No, one more thing I generally add on, like Dr. Arjun, you also can. See, normally I say no, with malignancy, there is known as microsomal spread. All of you are also, I'm not teaching anything out of, this is all what we are taught in our basics. What happens and the spread happens within is not visible to the naked eye or even the electronic eye. So that microsomal spread, somatic spread, so many ways of spread are there in all these, and especially with malignancy. So that is something to warn the patients always. So that is why are we doing repeat CT every 3 months or PET once in 6 months? These are the reasons which it can spread. Probability is there. So that also has to be conveyed to the patient and said that these are the things there. That's why we review, and we hope, all of us hope for the best. And then, but you have to go with what reality is, what comes up as a histopathological report. Based on that only, you're going to give the service and care.
Actually,
Can
madam,
we come?
yeah, the patient relatives are well known about all these things prior to surgery. They didn't want us to, that is my first question. They didn't want their mother to know in detail about anything. Whenever they come for review, I spoke to the doctors, they keep the mother outside the room after the checkup and everything. They are very adamant, they are very particular that they know the mother is having cancer, let her know that, but not about it, the full details. That
This
about
is where the
mental
big
spread.
style collusion is there.
Yeah. So they don't want to know. They are what exactly, actually speaking, they are just preventing us from communicating all those things in front of the patient.
So that's all there. Then you have to have a lengthy chat with the family to make sure where are we. So there you're in loggerheads there itself. So then you have to do two opposite things, one for the family and one for the patient, but the patient is asking you something totally opposite. So somewhere, so there, Sri Priya, if you could come out of this presentation, and so that everyone can just have, and Arjun, please go ahead and
So, ma'am,
And
like one thing which I felt was that like concern might have been given. One thing is she might have thought it might be a temporary colostomy actually. I think like based on a case which I found, like the entire presence of the near site of the colostomy itself is causing severe distress to the patient actually. Like seeing like it's a thing which when we commonly encounter, we also have actually. So what we ideally say is that like this might be an emergency colostomy. So whenever a colostomy is being planned, either making the patient meet with another person who's having colostomy itself, it improve their like they can improve the acceptance of what they are going to expect post the surgery actually. Like they can see how the colostomy bag is, what is how the contents are coming out through it, and so it will give us certain like it will might decrease the issues which they have post surgery actually, because not only colostomy for tracheostomy it's the same as what heard actually. Other thing is in this case post surgery the quality of life has been affected of the patient is what I can add. More than the physical symptom, the patient is having more of a psychological distress right now due to the presence of colostomy bag. The entire intent of the surgery might have been curative to help her actually, but due to the intervention, her quality of life might have been more affected. What I have a doubt. Like regarding no,
Yes, sir,
no,
you can continue, Dr. Arjun.
yeah.
Sorry for
go ahead,
that.
Arjun.
Other is regarding the pollution. Like you, as I mentioned, I think it's a bit more trickier here to as I manage the pollution here because the patient is well aware of a diagnosis actually, but and we need to have a discussion again because the major symptoms which major issues which she's having right now is entirely due to the pollution is what I feel like. She wants the back to be closed, but the caregivers are not close. So having a detailed discussion with them, again, what are their expectations and what is setting a realistic goal would be a better option for starting to address the pollution is what I feel.
On the chat box was an effort on the part of the doctors to encourage the son and daughter-in-law to tell their mother of her condition. If need arises, take help from the doctors. So basically, that's what like it would mean that you may have to have few discussions. What is that is why is the collusion in see generally we say love and affection is the reason for the collusion, but you may have to prod a little bit further. So when you tell them, because this is what your mother wants and this is reality, so if you don't tell, because and as Dr. Arjun was mentioning, you know, the patient is one who goes through the symptom. The family may have love and affection. One more thing I generally say, the patient is one who goes through the pain or goes through everything, so he or she has the utmost autonomy to make the decision.
Correct. That's the main reason I got up this case, because I had multiple cases of intestinal obstruction. I brought up this case as mainly for this discussion because it is actually, I felt very bad for the patient when I came to know about the whole story. That even after
So how
this,
is she now? How is she now? What is she having now?
actually, recently I have, when I was preparing this, submitting this case last month, I've contacted the relatives through a phone number. So they are saying she's still having that pain and everything, but her stoma is still functioning. They're trying to encourage her. Even palliative care people are coming home. Palliative people are visiting them and giving her pain. Everything is okay, but still she is in that phase of
Stomach care.
stomach. She doesn't want
No,
it.
see, no, like you said, she's very religious and all those type of people. Any of these bags and things, they from their point of view is something
Actually,
different.
she is very social. She goes house to nearby houses to help such patients. Everything she does, she's very social, very helpful lady, very active lady. So with this
Correct.
illness, she suddenly, you know,
So that's all. We have to try, see some social worker on the family and things. You may have a discussion and do something so that you bring up what is that she wants to do and do the best for her. See, always we have to do everything in the best interest of the patient.
only option I think, madam, closing her stoma is out of question. considering
no,
all
that's
those.
not.
So that all
So
those we
teaching
have
her.
to, yeah, watch. We cannot do what she demands, but we can.
No, see, we need not even say do what she demands. If you explain to her that that is the disease, she may
Disease,
say,
yeah.
no, if my life is in danger, I will learn to take care of the
Take
bag.
care of it.
Okay. So because she doesn't know the reality, you've not told her what is her prognosis of the disease, what
Yes,
is the stage of the disease. If she is
yes,
so well versed in everything, if you explain to
yes,
her, she will come to you and say, okay, teach me, how should I do? You can teach her to empty the bag frequently, reusable bags. So many things are there with all that. So why is that? You have to see, many times we say no. When you talk about total pain, you'll find out some economical or financial cause is the reason for the pain. There may not be a physical cause. So like that, if you ask her, maybe this bag is getting filled up frequently. So when I go, so you can tell her how frequently she can empty the bag. And there are so many things in that. Daily flushing the bag. There are there are umpteen
absolutely.
things. So all that can be taught to her, and then you can teach her how she could have a better quality of life. And she may say, no, I'm happy with the bag. So we should never assume. See, Dr. Agwan's session of everything, we are assuming that this is what she is. So don't assume, explain, and take steps to avoid the collusion. And if you do all that, then you can see, then you may not have any of the issues.
Last time when I contacted, as I told you, I asked them, especially palliative people, are they coming and training you and the mother regarding the stoma care? So they have told that they had showed us multiple options of stoma bags, and they have taught us also. And now the stoma site, excoriation, skin, everything has come down. It has come down. So hopefully with that, she might respond good with the palliative people support. They are coming to their house and taking care of the patient at frequent intervals. That's what I got the last feedback.
Radha ma'am, you are muted.
Sorry, Dr. Brojan Singh's hand is raised. You could unmute and ask whatever you want.
Okay, I'm just curious. Looks like the story is going a little far now. I just wanted to know whether the woman now have understood her condition or not. Now, at the beginning, the son and daughter-in-law, they refused to talk to the patient, so it wasn't told to her, this is the story so far. But now, since things have gone so far now, whether she have some assumption or anything about her condition now.
About that stage 4, I'm not sure, sir,
Not
because
about, not
uh,
exactly about the case, but about the condition that she has cancer. This is the
she knows
prognosis.
that she has malignancy. She knows that she has got a large bowel cancer. That at the time of admission during the surgery itself, she knows. But she doesn't. She that time she thought that it got cured with the surgery and the chemotherapy. That's what she thinks. So
That, that
eventually things have turned plate, and it turned out to be mental medicine and everything. So that at that moment the bystanders were reluctant to communicate the further story. So she knew she knows only the half story.
so the
So
first point
currently
that
I don't know how much they have conveyed to her. She is not following up with me. She is not
okay.
my patient. So I got the story till that, and this is what has happened in her life till a particular point of time.
Okay. In that case, the thing that you put up in the first point about whether to tell or not, the daughter-in-law in the son is refusing is a bit different now because he understands the condition. And probably we need to sit together and explain her about the prognosis also as well, since she knows that she's suffering from cancer and then about the stoma and all. Probably, I think more discussion, more sessions, because it might not be all in one, that might include even the son and the daughter-in-law.
Yes, sir.
Right?
That's what we need. We need to make them sit together and have a very healthy discussion.
Question of
First,
that
we should
ethical
discuss separately. So what I felt like, if I would have, I should first call them separately and have a discussion, and then make them come together and go to the point in depth. So
Yeah.
that's what, because she doesn't. Now what I heard is now they don't bring the patient to the hospital even. They come and take the medicine. Palliative care people go home and give her the necessary care. That's what I heard.
Okay.
But if I
Because
was in a situation initially, I would have done that.
and I want to say is basically then it is not an ethical problem for the first one that you put up. Rather, it is a denial by the patient and refusing to do certain things. So that goes in a little different way from the one that you put up there, whether to tell or not. That's an ethical dilemma.
No, what I wanted to know, whether I should surpass the bystanders and have a one-to-one talk directly with the patient and tell her without the consent of the bystander. Should I go ahead and talk to the patient as a responsible doctor, because she's conscious, well-oriented, comprehension,
What she
comprehensive?
wants, it depends on what she wants, what the patient wants, whether she wants to know the condition in detail or not. If she wants it, you have to do it. If she doesn't want it, you can't do that.
It was written in such a way that she was not aware about.
Okay, thank
Dr.
you.
Arjun, thank
Thank
you, Dr. Brojan. Exactly. That is where we are coming to, knowing what exactly the patient wants. And if she doesn't want, and then we have to tell her if you don't want, and these other things. So, but we can't assume anything. Only if you
Yeah.
ask, you will know
Ask,
where and
yes.
how.
Ma'am,
And
whether
Dr.
she
Arjun,
wants
you
to know
want to
or,
add on anything?
excuse me, madam, whether she wants to know or not, she thinks she knows the full story. That is the problem here.
Then in that
That
case,
is where
again,
she will
like in
not take an
spikes.
initiative to ask us what is my story. Is there anything that I'm missing out? She will not ask us. We are supposed to tell her, because she still
So
feels that she knows the full story of her illness.
then in that case, no, what you just have to do, if you think that you have to ask a few questions, what is it? Explain to us. Then you will know. Then, because we should not offend any patient also.
Yes, yes.
So if you ask her, please tell me what it is, what it is. So then okay, in that case, like same, it's like as we went through communication only, each word, what is that they've understood, how much knowledge they've gained from what we have said, what is that has gone through to them. So in that stage, you will know that she herself will come back, oh, this one you're asking, I don't know. So when she says, I don't know, that is when you explain.
Explain, yes. We have to go for her. She will not come to us.
Time,
That's what I
it's
feel.
matter of time. As
Yes.
we always say, you cannot do this in your outpatients when you're seeing 50 patients. You have to give some separate time. You're one of your suggestion, talk to her separately, talk to them separately, and then bring them together. It will be a bit of like a what to say. There may be some argument also at some point of time. So, but you do that separately and then get the concerns of both and then go through, and then it's you will need more time and
Yes.
thing to do that.
Yes.
And I was just asking if Dr. Arjun wants to add on anything more to the discussion, please.
No, ma'am.
Okay. There are no more. See, the first one, and then we had like the last two queries, that I think the multimodal team management is what will help in that. You have to get the help of social worker, psychologist and things too, because when you say all these things, the patient will be upset. Okay.
Yes.
First thing, you're unable to do what she wants. But again, what she wants, is it the best for her? If you explain, she herself might accept. So we have so many stages for which we don't know what the patient will reply. So here many queries are there. So it has to go step by step. And then is when we will be able to achieve at what is the goal of care that we can give, what is that she wants, and then what's finally provided or possible. So I will hand over to Sri Priya and Anup to move forward from there, please.
Thank you, madam.
Thank you, Dr. Arjun. Thank you so much for being with us for 2 sessions and walking us through one of the most important symptoms, the GI symptoms. And we do hope to have more fruitful sessions with you in future. Sorry about that. My voice is very much scratchy. And thank you everyone for joining in. And with the promise that we will meet again with another session and at the remaining faculty. This is Sri Priya along with Dr. Arjun M. Pillai, Dr. Radha Venkateshan, and Mr. Anup signing off from the Tips Eco Hub. See you in the next session. Till then, everyone take care. Bye-bye.
Thank you, Dr. Arjun. Thank you, one and all.